Hello, hi, I'm Elliot Fishman, and welcome to our Facebook Live. Today is April 29th, so we're about to finish the month of April, and the weather has kind of turned warm, and that's good. That's good. So, Baltimore was 88 degrees yesterday when I went home at about 7 o'clock, so it's a warm day. I'm sure it's warm today, and as we reach May, hopefully things will continue to get warm. In Baltimore, East Coast, one of the only downsides of it getting warm, the in Maryland and many of the eastern states, there's something called cicadas. Those are these bugs that hibernate for 17 years and they come out every 17 years. They make a crap load of noise, and they're not poisonous and they don't bite you, but there's so many of them. It's like locusts, like in the Bible, the 10 plagues. There's so many of them, and they cover the trees and they cover the people, and they run into your car and they run into your house. It's just simply plain disgusting. So, and it lasts for like 2 or 3 weeks, so it's really annoying. So cicadas come, I think, when the ground is 70 degrees, and then they start hatching and they come up. And I'm not going to go into the gruesome details, but cicadas are on the way. Anyway, I hope everybody is doing well. You look at the numbers on the COVID, it's getting better. Even the states that were doing worse are doing better. If you want to be optimistic, you look at the state of Israel. 60% of the entire population has been vaccinated, and 90% of patients over 50, which means more vulnerable people, have been vaccinated. And Israel's down to the 70 or 80 cases a day in the country. The country is about 8 million people. Very little hospitalizations. Most of the COVID wards have been closed. Now, again, people do get sick, but the ones who get sick don't get that sick, and hospitalization is rare. So I think that's going to become very important. And so it's something we can look forward to here, hopefully. CDC had new regulations this week about being outside and not wearing a mask, but then they said if you go to a baseball game, you have to wear a mask. If you go to a concert, you should wear a mask. So it's kind of a little bit fuzzy. I think people will read into it what they want. Personally, I'm very careful. I'm wearing a mask everywhere. Even by myself, I wear a mask. No, I got a mask. Where's my mask? Somewhere around here, somewhere. I'm not, speaking on Facebook Live, someone said, do you wear a mask on Facebook Live? Because you're speaking to a lot of people. I think that people did not quite understand the principle of Facebook Live, that I may be here and I'm live, but you're home and I am not breathing on you and you're not breathing on me. So that makes it very simple. So the rules will constantly, and everyone will interpret the rules differently. So I think at the end of the day, being careful is not a bad thing. But hopefully, things are getting better and better all the time. So this talk is on IV contrast material and CT. So one of the things I think that we've noticed with COVID, and this is not so, I don't want to be obnoxious about this, but as people did not travel, you saw a lot more outside CT scans than ever. And that was true for all sorts of parts of what we do, including pancreatic conference. But across the board, we see a lot more outside scans. One of the things you notice, the outside scans just aren't as good as they should be. Now, everyone always complains about everybody else. It's kind of like I always joke when I give a talk on misdiagnosis. A misdiagnosis always happened at an outside hospital. Now, who those outside people are and how terrible they are, we know that. We don't know who they are, but it's not us, it's them. So one of the things we do notice is that the quality of the scans are not that good. Now, I'm not saying the quality is not good because they have 4 slices. They have a 20-year-old scanner. We sometimes see 16-slice scanners. I've not seen a 4 in a long time. But most of the people, 90% of people have a 64-slice or better. The problem is they don't do it very well. So the problems I see are, 1, lack of oral contrast, poor timing of oral contrast, but most importantly, the lack of oral contrast. People do not want to give oral contrast for whatever reason. It doesn't make any sense. I know initially there was concerns about people taking their mask off and drinking and perhaps contamination, but even now it's a little bit simpler. People are vaccinated by themselves. Still, doesn't work. But this is not an oral contrast talk. Let's talk IV contrast. So first of all, we're seeing more in the ER setting when they don't want to give IV contrast. It makes no sense to me. CT diagnoses will be missed without IV contrast, whether it's lesions in the liver or the pancreas or the spleen or the kidneys or the bowel. If you don't give IV contrast, you miss so much. Yes, you're going to pick up a 10 centimeter pancreatic mass, but there's a good chance you're going to miss a 2 centimeter mass. The signs, the perfusion changes, the vessel, the enhancement patterns, all of the things that CT really excels at do not do well when you don't give IV contrast. You need to give IV contrast. Now, giving IV contrast is not the end-all and end-all either, because it's a question of how you inject the patient, how your timing is. If you're injecting 1 to 2 cc's a second, it's going to be a crappy study. You need to be injecting at least 3, but ideally 4 or 5 cc's. When you inject quickly, get the contrast in, and your volume's 100 to 120 cc's of contrast, you will get a really good study. Your vessels will be very bright, and every CT you do will have, in some sense, an angiographic quality. You'll be able to be, in a sense, arterial phase. If you're looking to detect the pancreatic mass, of course, neuroendocrine tumors are only seen usually in arterial phase, but also the vascularity for staging celiac and SMA are much more accurate in the arterial phase. The venous phase is good for picking up adenocarcinomas, but you'll miss neuroendocrine tumors. It's good for looking at the portal vein and SMV, but not as good for looking at the arterial structures. Now, when you time things, arterial is, let's say, 30 to 40 seconds. You're injecting 5 cc's a second, and venous tends to be, let's say, 70 seconds. But if you're scanning at like 3 minutes, the contrast is excreted in the kidneys, the contrast in the aorta, and the IVC is almost the same. It's not very good. You're not having an arterial phase, you're not having a venous phase, you're having a something or other phase. You're having a phase that's not that good for anything. Now, we know excretory phase, which is at 4 to 5 minutes, is really good for looking at the ureters, looking at the calyces, looking for extravasation, looking for transitional cell carcinoma. It's often good for the ureter and bladder. We know that. But if you're doing the pancreas, a 4 or 5 minute scan is of no value. Now, I know there was an article published in Radiology or AJR, I can't remember which one, maybe it was AJR last month, that made the point that sometimes you pick up small pancreatic lesions on delayed phase imaging that you don't see in arterial or venous, but that's exceedingly rare, and I could have seen those tumors on the arterial and venous anyway. But if you don't have the timing right, you're going to miss a lot of lesions. If you don't have the timing right, you're not going to be able to use that data set for AI. If you don't have the timing right and the timing consistent from scan A to scan B to scan C, you're not going to be able to tell the oncologist whether the tumor has grown, got smaller, or stayed the same with any certainty, particularly when the tumors are relatively small. Now, if something goes from 3 to 8 centimeters, or goes from 8 to 3 centimeters, okay, that's easy. But when you're looking at subtle changes in oncology patients where they want me to know, Elliot, should we change the protocol? Is the tumor smaller, bigger, or the same? You want to be able to give an accurate answer, kind of, it's about the same. I think it's bigger. I think it's smaller. That's not really answers. You need to have science. You need to measure. You need to really get things on the money. So the delivery of contrast and timing of contrast becomes critical. Now, let me just say hi, Liliana, who's coming in from, if you touch on her thing, it says Barcelona, Spain, but that's original. Now she's out in Palo Alto, California. And Mackenzie Gold is from, lives in Riyadh. Okay, that's pretty far. I've never been to Riyadh. Hopefully someday we'll be able to get there after we get past COVID. But so we got people from 10,000 miles apart and about 11 time zones apart. I think one of the things, we talk about is designing protocols. And if you look at CTisus, the website, still one of our most common areas of interest is where people do look at the protocols. We update them yearly. We're trying to update the specific scanners, like beyond Siemens to GE and Philips, Toshiba. It's a little bit tricky. We're trying to get them to help, but the companies aren't always as helpful as they could be. But I think the point being is you need to have good protocols. If you're not sure what protocols to do, you can look at CTisus and get some idea and perhaps modify the protocols. Or what you could do is ask your vendor. All vendors have recommended protocols for your scanner that combines good quality and a reasonable dose. So you want to be able to do that as well. But you have to, once you have the protocols, then you have to follow the protocols. So for example, we've had this issue with pancreas cancer and the study's not being good. Well, there's an article published 2014, a combination of the American Gastrointestinal Association and the Society of Abdominal Radiology, which goes through pancreas and has all the protocols, all the techniques about dual phase imaging, about 3D mapping. Yet 90% of the cases on the outside we get of the pancreas, which should be 2 phases, are 1 phase, and it's neither venous nor arterial. So people are not following the rules. So it's not a matter of not the ability to do it or not an understanding of what to do, they're just not doing it. And whether you want to blame the radiologist's fault, or it's a technologist's fault, or it's the administration's fault, or it's society's fault, it doesn't matter. At the end of the day, when you're the radiologist or you're the technologist, it's your fault. You need to do the studies correctly. Detecting disease often is hard, but it's impossible unless you have the protocols. IV is critical. IV is critical for lesion detection. Arterial phase imaging, best seen arterial. Venous phase imaging, best seen on venous. Staging, looking at the arterial structures in the pancreas, celiac and SMA. In the kidneys, looking at the renal artery, the aorta, the renal vein will also become important. So depending on the application, different vessels may be important, but at the end of the day, vessels are always important. In my mind, the reason 64 and better CT really works, it's because it makes everybody into an angiogram. Every study we do, whether it's an aorta, whether it's a coronary or a pancreas or a liver or a kidney, is really an angiogram, because when we do arterial phase imaging, we have a wonderful map of the arteries and the key vessels. And we do venous phase imaging, we have a good map of the IVC and the key venous structures. You combine them both together with a dual phase acquisition, you have incredible amounts of vascular data, essentially better than any angiogram. And it's just really why CT can be so good, but it's dependent on you doing the protocols correctly. So I'll just comment, there's probably a good time if you have any questions to ask. I see, I can't pronounce the person's name, but I think they said Ciao from Italy, so that's not their name, it's not Ciao, but I can't read their name. So, you know, one thing is interesting, so California, USA, Riyadh, Saudi Arabia, and Italy, wherever from in Italy, whether you're any of those places, the scanners, the contrast, the injectors are pretty much the same. It's really a matter of really doing the protocols correctly. An important thing, of course, is vascular access. 18 to 20 gauge catheters you need to have to be able to inject 4 or 5 cc's. If you have one of these new catheters like Becton Dickinson cells with multiple side holes, then it's much easier to put a larger catheter in, like a 20, and still be able to inject your 5 cc's a second. So that becomes very important. And I've just been clarified, that was Nick from Italy. Italy's a big place, but hopefully they're, I know their numbers were kind of miserable on COVID, but hopefully it's getting better there. I know it's getting better. I spoke to a friend in Germany, so hopefully Western Europe and the Panhandle, where Italy is, Mediterranean area, is getting better. We can hope for that. So that's very important to me. I think it's really critical to really take a look at how you deliver IV contrast, whether it's an aorta for an aneurysm or dissection, whether it's a kidney and looking at a renal mass and you want to determine vascularity. Remember, vascular lesions are clear cell and hypovasculars are going to be papillaries. So the importance of being able to not just say there's a renal mass, but say clear versus papillary becomes important in planning surgery and planning partial nephrectomy and in planning treatment. Yes, you're going to get path, but how we go about getting path and how we go about planning the study becomes critically different, whether we're suspecting clear cell or papillary or chromophore or oncocytoma or whatever. Okay. Here's a comment from Scott. We use spectral CT. We can reduce contrast significantly and reconstruct low KEV images? How long can we go with respect to contrast dosing to look at adequate organ enhancement? You know, I think it varies, it depends on your experience. I think some people really like the dual energy and particularly monoenergetic. We like it for some things like pancreas we haven't been that fond of. I see a lot of the cases on the outside with dual energy, the images look noisy, the ability to detect small tumors is kind of hard. I think one of the things also with dual energy that concerns me a little bit is AI. You know, AI requires reproducibility of protocols. If everyone is constantly varying the protocol with spectral and multi-energy CT, it can be somewhat problematic long term as we look at the impact of AI. So that's something to be very interesting. There was just an article today I was looking at from Mayo Clinic in Rochester where they made the point that the data sets for CT for AI are so poor in the public data sets, which is why things are moving forward. You need good data sets. And we know from our own work with AI, unless you have good data sets, you can't really do much. So you need quality scans. I think that becomes very, very important. So if you're a technologist and you don't like to look at your scans or you think there's an issue, I would speak to the radiologist. Now, I know one challenge where things have gone downhill is radiologists are often remote now. Many of them were near the technologists, but now people are reading from home, they're reading from a different office, they're reading from down the hall, down the street, across the nation, all over the world. When you're near someone and you're not walking in the reading room or you're not walking in the scanning areas like maybe you used to, where you can just say, hey, what's happening, what's this, what's that, and why you do this. So there's a lot less communications, and that's just one of the downsides of COVID. I think as we start coming back together, that will be less of an issue, but surely when people are separated, you just want to get the work done. The protocols perhaps become less important. There's less commentary, there's less ask on how I should do the study and just do the study. So I think that becomes very important. And COVID has been, I think, a killer for image quality, a killer for quality assurance. I think people have worked super hard, techs, radiologists, have worked very hard to try to get our patients taken care of. So it's not been perfect. So I do not in any way, shape, or form want to be critical, but we all have kind of taken shortcuts and we kind of let things go by. We never would have let things go by before. So I think as we begin to come out of COVID, we have to step up our game. We got to get back to the best protocols. Some of the things we learned to do and the habits we developed need to change or go back to what it was before, or just change and make it better. I think one of the things with COVID is we did it. We got through it. We did enough. But I just think as you go forward from COVID, doing enough and getting by is not going to be a strategy. I don't think that strategy is going to work really well. So that's kind of my take on the situation. If anyone has any questions, it's a good time to ask. I will tell you that I do the speaker series. There's an article published today from Bill Brody, who spoke a few months ago. There's an article the other week from Keith Grossman, who was from Head of Time, who spoke a couple of months ago. We have articles with Eric Becker and Stu Eisenstadt that are in the final processing of being done and going to them. We have other articles that are being written. We have a new speaker this week. We have two people from Microsoft AI. So that's going to be really, really exciting. Jason Kravitz is one of them. So we're going to see a lot of good stuff. I wish I could invite you if you want to come listen. 5 o'clock on Tuesday, I probably can give you a link. I'm afraid of putting the link on CTisus. We have so many users, and then you also have some annoying people who just try to make mischief. And the one time we posted things, we had a bunch of people just trying to Zoom us to death. But now Zoom has gotten better, but I don't want to take a chance when I have a speaker online. So with that, I hope everyone continues to do well, and to our friends in Italy, Nick, who says it's slowly getting better. I hope it slowly keeps getting better and things speed up. I hope everybody is doing well, and if you have any comments or questions, feel free to give us a call. You can email us, link into us. We will answer. We will be there. And with that, have a great day.